Evening, ladies and gentlemen, and dear friends, welcome to this event co-hosted by the WHA Federation and Cardio for Cities Accelerator. My name is Jean-Luc Kaiserle, I'm the CEO of the WHA Federation, and it's my pleasure to welcome you with Annert, the head of the Novartis Foundation. Let me just start with an anecdote, something I heard a few years ago. It was a study in Atlanta on heart failure patients, and they were trying to improve patient outcome. And from all the measures they did in Atlanta, the most impactful was constructing a bus line between the poor suburban area and the hospital. I think it illustrates the power of environment, prevention, this early detection and management in addressing cardiovascular in the city. And we are going to learn tonight more of this exciting news and exciting information. WHA Federation is a kind of UN of cardiac societies. We have 220 members around the world. We work with WHO as an official partner. And a lot of our work is based on countries. But as we move towards the UN high-level meeting, the message is implementation, implementation, implementation. We need results. We need to move from policy from results. And that's why WHA is so interested and committed to this initiative. And I'm very proud and honored to announce tonight that the World Heart Federation has decided and has been accepted to become the scientific partner of Cardio for Cities. Very pleased about this. Before passing the microphone to Watson, let me just emphasize one recent document we published with the support of Novartis Foundation, the World Heart Report on Air Pollution and Cardiovascular Disease. It's a fantastic document launched on Saturday, which has huge major coverage. It's based on the data of the observatory, another important element of our strategy in terms of data collection and dissemination. So thank you very much to all of you for being tonight, and to you to learn.
Thank you, Jean-Luc, and welcome also in the name of the Novartis Foundation. It's my pleasure to welcome you all tonight. This event is based on our work at the Novartis Foundation, and specifically on a whole-of-city approach we have validated throughout different continents, which is called Cardio for Cities. And Cardio for Cities was a multi-sector partnership, so with public and private sector players, but also from different disciplines, be it health, education, workplace health, or food sector, transport sector. We work together with everybody to truly drive cardiovascular health in large populations. We leveraged activities within and outside the health system and the health facilities. And at the same time, the success of this initiative has been thanks to the local ownership. Every Cardio for Cities approach was driven by the local city authorities and their partners. It was driven by data. So we used real-time data to constantly monitor where the interventions had to focus. So we readapted in very agile way the interventions according to the periodic review of the real-time data. And that made its success. Cardio for Cities in São Paulo, for example, in 1 year of implementation, we were able to triple the blood pressure control rates, and that translated into a reduction of up to 13% of strokes. And in reality, it was even more, because we have afterwards measured these stroke reductions in real time. So it is a very successful initiative that we are so happy to bring to many more cities in the world in partnership with fantastic players and partners like the World Heart Federation and many others you will see here around the table tonight. So thank you for coming. Our focus on cities is based on the fact that almost more than half of the people live in cities. And we know that in a few years from now, this will be around 75% of the world's population. So cities are the examples that can drive population health worldwide. That's what I invite you to discuss with us tonight. Thank you and welcome. Thank you, Annie. With this, I think I stay on this microphone. I would like to introduce a very short welcome video from the steer committee chairman, who is Honorable Greg Hunt from Australia, former Minister of Health in Australia, and he could unfortunately not be with us, but he sent us a very short video to welcome you all.
Well, welcome everybody to the World Heart Federation and Novartis Foundation whole of city approach to cardiovascular health and care. We know that this is our biggest single health problem. Death by cardiovascular disease causes more heartbreak and more tragedy than any other condition, and in particular than any other avoidable condition worldwide. We also know that 70% of the population lives in our cities, and therefore it's a natural focus to look to our cities to help as a foundation for addressing cardiovascular disease. Against that background, this forum, the broader Cardio for Cities program, think of it as the global cardiovascular mission, is aimed at taking the lessons from an initial 3 cities, expanding those to 30 cities to help protect or save and improve 150 million lives, and then to work on that as a global program both in our urban and rural areas. The playbook is about practical, specific things which can be done in each city on a tailored basis with the support of the Heart Federation and the Novartis Foundation and leaders in all of the different jurisdictions. It's possible to prevent, to screen, to improve awareness, to improve treatments, and to improve outcomes. We've seen that, we've shown that, but with your help, we can take this worldwide and make our cities safer places with less cardiovascular loss of life, and in turn, that will make a difference, not just to thousands, not just to tens of thousands, but to millions of lives globally.
Hello everyone. I'm Shuli Ghosh and I'm going to be your host for this discussion. We've already heard from Anne, thank you, and Jean-Luc about the what a difference it makes if you drill down to a city level and use an evidence-based approach and collaborate across different sectors. So we have a fantastic panel of speakers who are going to be helping us explore the Cardio for Cities potential and initiatives and how it can be replicated and scaled up. But first, let's hear about the importance of data-driven decision-making in cardiovascular population health. Please welcome Professor Michelle Williams, former Dean of the Harvard School of Public Health, Professor of Epidemiology and Public Health.
Thank you. Good afternoon, everyone. I have to turn this on. Now you can hear me. Good afternoon, everyone. I'm delighted to be here, and I just want to start with a little bit of a story to underscore why a whole city approach is important. If you remember anything that I say, remember this: health is more than healthcare. Essentially, this is an argument that can be supported by this little story I tell you. Several years ago, I was at a conference where a reproductive endocrinologist, educator, and practitioner lamented that his patient, a woman with gestational diabetes, a medical complication of pregnancy that puts her at high risk for an adverse pregnancy outcome, that puts her at high risk for cardiometabolic disorders as she ages out of her reproductive years, and importantly, that puts her newborn at risk for cardiometabolic disorders when the baby is born macrosomic or too big. Now, this endocrinologist was concerned that the patient was not following the recommended behavioral changes. What were those behavioral changes? To decrease the consumption of highly processed foods and increase the consumption of fresh fruits and vegetables, to increase her physical activity by going for long walks, preferably in the morning before it gets too warm, and by working to control her psychosocial stress factors. Now, that prescription is not a prescription where you go to the pharmacy and fill it. It is a prescription where the behavior changes are either supported or not supported by the place where she lives. And that's why I say health is more than health care. I am, in addition to being an academic, a strong proponent of the kinds of partnerships you just heard Anne talk about. Population health requires all of us to be engaged, especially those of us who have leadership roles in cities. Why do I say that? Well, I will tell you that one of the benefits of public health came through cities taking the responsibility of managing waste and water to allow us to gather and convene in cities healthfully so that we could drive the development of our economy and our social society. I'm talking about the 1840s. Today, because we have controlled so much of the infectious disease threats to our population, we now have to turn our attention, as you heard, to non-communicable diseases, particularly cardiovascular disease, the #1 killer of the globe, population around the globe, with 18 million lives lost per year, and a third of those lives lost prematurely before the age of 70. Now, why cities? Cities are where the environment that can enable health and wellness begins. It is the cities that provide for our food environment, that provides the transportation that you heard referenced earlier, that provides water and waste management, but also supports our access to energy and green space and housing. What I'm describing are the social determinants of health. The drivers are health. These drivers are outside of the healthcare system, upstream to the system of medical care that accounts for upwards of 80% of our health and wellness. So what does that mean for us practically? What it means for us practically is to take a comprehensive, holistic approach that brings together medical care and the drivers of health that's outside of medical care, and do it in a system that is coordinated, that is evidence-based, that supports decision-making, and enables us to invest in interventions, targeted interventions that drive down morbidity and mortality, particularly for cardiovascular disease and diseases like diabetes. So I'm proud to be engaged in this public-private, and I will add academic partnership, because population health requires all of us, particularly those who have governance roles in cities. I'm proud to be the co-chair of another initiative that is the AI for Healthy Cities, which is complementary to Cardio for Cities. Why is this a second initiative by the Novartis Foundation important? It's important because this initiative, AI for Healthy Cities, harnesses real-world data in the most holistic manner: population health data, vital records data, health systems data, behavioral data, and uses advanced analytics, deep learning, machine learning, to help us identify, specific to communities, specific to zip codes within communities, which interventions might yield the highest impact. This is an important complement to the Cardio for Healthy Cities. Cardio for Cities is really managing the condition, but AI for Healthy City can help do that and also move upstream towards promoting and preventing the conditions that drive cardiovascular death. So I'm delighted to be a part of this conversation, delighted to be a faculty member engaged in a public, private, and academic partnership that is driving to improve cardiovascular health and also to address the ever-increasing challenge of health disparities. We are starting our work for the AI for Healthy Cities in 4 cities, but it's just the start. We will be expanding, as Anne will share, I'm sure, later. But right now, we are working with the City of New York. We are working with Helsinki, Basel, and Singapore. And this is just the beginning of helping city leaders harness the information from their own data to get the insights that will promote action towards producing a healthier community. So thank you for your attention. I hope that you will join us in this endeavor, and I hope that you will see from this conversation how complementary these two initiatives are. They're action-oriented. Our goal is to translate what we know into what we do, and to use information to make smart decisions of how to invest in health and wellness. Thank you.
Thank you. Thank you very much indeed. So I am delighted now to introduce our panel. We have 6 brilliant speakers. I'm going to start on this side. I probably don't need to introduce Anne again, but I will anyway. Dr. Anne Ertz, head of the Novartis Foundation. We have Dr. Mohammed bin Hamad Al Thani, director of the Public Health Department, Ministry of Public Health in Qatar. Welcome. And Dr. Ashwin Vasan, Commissioner of the Department of Health and Mental Hygiene in New York City. On my left, we have Dr. Jagat Narula, President-elect of the World Heart Federation, Professor Stephen Nichols, Programme Director at the Victorian Heart Hospital, Monash Heart and Intensive Care, and President of the Cardiac Society of Australia and New Zealand, and Dr. Lillian Mbao, the CEO of the Kenya Cardiac Society. Welcome to all my speakers. Yes. Thank you. And there will be an opportunity to put some questions to them at the end, because this is also an opportunity for you to find out how Cardiophysities is working and could work in other places. So let us start with New York City then. Ashwin, you've got a very ambitious goal to expand life expectancy in New York City to more than 83 by 2030. You've got a roadmap. Obviously, cardiovascular health is part of that roadmap. How are you aiming to reduce premature cardiovascular deaths?
Well, first let me say it's great to be here. Thank you to Anne, thank you to Novartis Foundation and World Heart Federation for having me. We are a proud partner in the AI for Healthy Cities consortium, and I echo Dean Williams's remarks. Data is very much our superpower, and it is the basis for our insights, particularly in a role like mine. So my title, I have many titles, but one of the titles is, they say it's the city's doctor. And so if you think about that, that means I've got 8.8 million patients, and I can't leave any of them behind. What that also means is that I've got to really think about population health, not in the way that a hospital might think about it, or a primary care provider might think about it, or even an executive might think about it, an employer, but rather I have to think about the whole geographic area, and I have to think about population health at an area level and plan at that level. And so when we saw during COVID that when we know what the enemy is, we can actually galvanize quite a unified approach. Yes, there were plenty of challenges, plenty of problems, but we had public, private, nonprofit, philanthropic pillars of our civic infrastructure working in alignment against one enemy, one goal. So we asked ourselves the question in the post-COVID, post-emergency era, what is that goal? What is the health agenda for the city? And when we started to unpack our lifespan data, our life expectancy data contained in our vital registries, it was quite alarming. As might be expected, 2020 was a particularly difficult year for New York City. We experienced the steepest loss in lifespan in the entire world, almost 5 years of life expectancy loss in 1 year, mostly because that's 50% of our COVID deaths happened in the first 3 months. A painful story. But as we started to unpack 2021 and preliminary results from 2022, we see that while there has been improvement largely due to COVID's waning effect, we are nowhere near where we were in 2019. The story prior to 2019 is not a positive one in the United States or in New York City. It's one of stagnation. And we have deep and abiding inequities by race, by class, by socioeconomic status in our city.
And presumably this is where the AI for Healthy Cities data comes in to allow you to know where to focus resources.
And cardiovascular disease remains our leading cause of death in New York City, stubborn as it is, and diabetes is number 4. So cardiometabolic disease together is a massive priority. When we talk about reaching our goal of hitting a life expectancy, our highest ever, 83 years by 2030, we can quantify that. That's an estimated 7,300 preventable deaths that we have to avert by 2030, and a big fraction of those are cardiovascular deaths. And so, when we think about an initiative like AI for Healthy Cities, when we think about our population health agenda, Healthy NYC, we not only need to lay out a roadmap of interventions all the way from upstream risk factor reduction like salt labeling and salt reduction and continued tobacco reduction like banning menthol and eventually getting towards a tobacco-free generation, banning nicotine products targeting at kids, which are a gateway product to tobacco use, calorie labeling, sugar labeling. We just passed a law called the Sweet Truth Act to start sugar labeling in New York City, and nutrition access. Those are our upstream interventions, but we also have to be taking seriously some of the newer downstream interventions. Obesity medications are a game changer, and we at our own peril ignore them in public health as a part of our comprehensive portfolio of interventions. So all of that is to say, none of that's possible without the best data. I need to know, as the city's doctor, not just what to put my dollars into, but where. At the neighborhood level, at the zip code level, because I know exactly where those premature deaths are happening. Deaths below age 65, they're largely happening in communities of color, which have been historically disinvested in. And so now I have an insight, a dashboard that gives me the ability to say, well, let me proportionally overinvest or correctly invest where the deaths are happening. And so that's the process we're beginning now.
It does seem, as the Americans like to say, a no-brainer to me. So it does seem like something that would be extremely useful in other settings. Let me come to you, Dr. Al-Thani. Countries like Qatar, I've been to Qatar, very successful health system there. You seem to successfully bridge what look like to be two different concepts, precision medicine and population health, which of course is what fundamentally Cardio for Cities is based on. Tell me a bit about the health system in Qatar and how your approach benefits both patients and the health system.
Yes, thank you so much. I'm very happy to be with you here. And as you know Qatar very well, maybe from the World Cup, maybe Al Jazeera, and maybe Qatar Airways. So you know that. But to be frank, that one of the best investments in Qatar in the last 30 years was not on these three. It was mainly in health and education. And maybe in health was more clearly than education, because maybe education started even earlier. But health, we are trying to be much better every year, and we are still investing in health. It's very difficult to work with health because it's very sophisticated and you cannot succeed quickly. But with the help of the different efforts, Qatar was marked 18 in health care in the world. It ranked 18 in the world. And during the COVID, we were one of the best 15 countries. And to go back to cardiovascular, to focus here more on cardiac challenge, Qatar has very sensitive issue that we should not die in Qatar as easily. So we built a lot of strong emergency system, ambulance system and emergency to catch up people as early as possible. So if you call anyone in Qatar, the ambulance will come to you in 8 minutes and 90% of the situation in 8 minutes. So you have a big chance to be saved from cardiovascular for this reason. At the same time, you need to end by having a good, excellent hospital. Maybe you can make people with orthopedic travel to another country, but cardiac will not wait. You should have it in the same time. So we have a great, doctors and system to have a good heart hospital in Qatar for the emergency. So after we built this, we found a lot of cases happening, and we need to fix it. So we went down and we worked more on the primary health care, and now we have a screening, a national screening program that anyone will be called every year to be tested for blood test to see if they have any risk later. And as you know, Qatar, one of the best things, if you who lived in Qatar, number one, people love Qatar for safety and security, and number two is for free health and high quality health for almost everyone. So this is that people help them to have a lot of tests for heart when needed, cheaper, and to have some early prevention systems. But as you know, people are people. They are not always reluctant, and they don't want to come always. Other than that we start to work on more prevention. So because Qatar is one of the highest countries in diabetes, we have even obesity and overweight was high. We start investing more in prevention programs, and we have taxes now on tobacco. And the last results say that we could lower tobacco in Qatar, smoking from 16% in the adult to 12%. And even in the students from 13 to 8%. So
you have reduced it, or you
both,
could
yeah.
reduce it?
We reduced in the last around in young age it was. The last 15 years, we went 25%. In the adult age, in the last 9 years, we went 25% too. So this helped us by taxes and awareness for tobacco. And at the same time, with early family counseling and primary health care helped us a lot to deliver this one. The thing that helped Qatar, we try to get things as early as possible now. So our system, our hospitals are accredited by mainly from GCI. Our primary health care have the diamond from Canada. And we are the only country outside the USA to have public health accreditation. Right. So we are trying to go by the book, by things that help us to be more ready for like this experience. Now we are very excited to be here with this experience because I believe we're working hard to make these things happen together. Our have a prestigious university in Qatar Foundation, and Qatar University is one of the best 200 universities around the world. So it's the time for us to go more sophisticated by these experiments. And Qatar is one of the rare countries in WHO to have all their cities, healthy cities are all accredited healthy cities. So this is, we want to build now cardiac on this healthy cities coming on. The other thing,
sorry to interrupt, can I ask, are you making use of data as well? Because you've clearly got excellent facilities and decent amount of resources, but are you using data to know where the problem areas are?
Yes, exactly. Thank you. That's what we're coming to. Yeah, exactly. We have a Cerner in Qatar connecting the hospital with primary health care. Very rare countries to have hospital connected to primary health care in one system. And this helped us a lot during COVID, that we were monitoring people, even from the doctors from their home and the patient from their home, and sending things through the post office, the medicine. So this data we are collecting, it was very more sharpened during the COVID, and now we are using this to understand people as early as possible and to target the high-risk patient. You can get from the data, you extract the data and see the high-risk people and have a stronger chance to call them to be checked as early as possible. We are hoping in the coming 2 years, we have data exchange system for all the country in one system, so we can follow all the people and assure that they are using our national guidelines for cardiovascular and other diseases. So this will improve the system. Plus, as Dr. Ann knows, that we are having maybe around 15% of our population already tested for genetic testing and in the biobank, and we know what do they need maybe in the future to support them, and we will follow them every 5 years. Thank you.
Thank you. Thank you very much indeed. Jagat, let me come to you because the World Heart Summit was just a few days ago. There was a lot of talk, as always, about the urgency of having to bring down the number of cardiovascular deaths. How, just give us a sense of the urgency with which we have to act to implement these kind of effective, evidence-based programs which have been proven to work, particularly in low and middle-income countries.
Thank you, Shivali. And again, it's a pleasure to be here. And as you know, Shivali is a very tough host. Yesterday morning, I received an email from her, which was not an email, it was a warning. And the warning was, I'll not give you more than 2 minutes. You speak a lot. Write down the points that you want to say. And don't say.
I think you're proving my point, though.
So, yeah. I said that without opening up the mic, so now I'll start. So, the global burden of cardiovascular disease is growing. And it remains the leading cause of mortality, as Ashwin just said. And both in developing countries as well as in developed countries, and both in men as well as women. Even though we have made tremendous progress in management of cardiovascular disease, and mortality has come down crashingly at the patient level, but it has come at a massive cost, right? Since cardiovascular disease is largely preventable, as Ashwin just said, the real-world interventions at the population level can significantly reduce the disease burden, and their timely implementation could ensure optimal allocation of limited healthcare resources to reduce the healthcare cost. Now, while the urgency is universal, the strategies and priorities must be tailored to the specific needs and capabilities of different regions. In high-income countries, the focus is on optimizing existing healthcare systems and addressing lifestyle-related risk factors. These settings have the infrastructure to implement advanced interventions relatively quickly if there was a will. Conversely, in the low and middle income countries, they face challenges like limited healthcare infrastructure, inadequate funding, and high prevalence of untreated risk factors. In these countries, the urgency is even greater due to the need for basic, cost-effective, and scalable intervention that address the social determinants of health and equity. Now, it is essentially the population approach. The urban approach is the population approach because the cities are the hub of dense populations, right? So imagine what we were born with when it comes to cholesterol. Can I bring down the level of cholesterol in the community to the level I was born with? Or something similar, what Ashwin will say, for the hypertension or for the smoking. Can we really do that so that there was not even a chance that these events are going to occur? Now, obviously, the intervention, a level of intervention, way of intervention, everything would be different and would need to be tailored to the different societies. But yes, the need is urgent and immediate.
Can I ask, I know that the World Heart Federation is also very committed to collecting global data. You collect them from countries and from your partners on cardiovascular health, and you make it available to everyone through the World Heart Observatory. Tell us a bit more about that and tell us why that is important.
So, World Heart Observatory is a pivotal initiation by the World Heart Federation, which is aimed at collating, streamlining, and disseminating the data on cardiovascular health and disease. This platform gathers information predominantly from within the umbrella of the Institute of Health Metrics and Evaluation, and is heavily enriched with data provided by partner societies and foundations from various countries of the WHA network. The observatory focuses on tracking trends in cardiovascular disease prevalence, risk factors, healthcare access, and outcomes. And the data collected are openly available to researchers, healthcare providers, and policymakers to make informed decisions based on the latest evidence. As more countries and organizations contribute data, its use is expanding globally, with countries utilizing the data to identify gaps in their healthcare systems, develop targeted interventions, and monitor the impact of public health initiatives. It is our expectation that the observatory data would become an indispensable tool in global fight against cardiovascular disease. And Professor Williams just said that the data is the most important thing here. And it should be instrumental in shaping national health policies, guiding resource allocation, and informing the public health campaigns. I haven't exceeded 2 minutes.
I was going to say your timekeeping skills are absolutely perfect. Thank you very much indeed. Stephen, and I am not keeping a stopwatch on this, so but the Australia-Pacific region, one of the highest cardiovascular mortality rates in the world. Also dealing with other factors like climate change and shortage of trained health staff. So how does the Cardio for Cities approach help mitigate all those things, that burden?
Well, we face the same issues that we've been hearing about already. It remains the single biggest disease burden despite all of the advances. And certainly in my country, which is a high-income country, this shouldn't be an issue today. We've opened a heart hospital 12 months ago. We shouldn't be opening heart hospitals if we got this right. You know, Michelle talked about the difference between health and healthcare, and I talk a lot about the difference between people and patients. I don't want these people to be patients of mine in the first place. We know that most of this is preventable. We know that the first time somebody has a heart attack, it's 1 in 4 of those people. It's the first time they've ever had a symptom. We know that 1 in 4 people who have a heart attack don't make it to hospital. So prevention is going to be the single most important thing we can do. Yes, we need technical advances at the other end, and heart hospitals and advanced centres can be important for that. But we are going to make the single biggest advances by thinking about how do we really move that out into the community. And then when you start to think about our neighbours, that's where the problem is amplified to a much greater degree. We know that the single highest rates of cardiovascular disease are in those Pacific nations in the Western Pacific. High rates of cardiovascular disease, poor access to the basic forms of preventative care that we could place today. We see that with our own Indigenous nation, community, and that worries many of us. So we need to be able to think about how do we apply these types of strategies, how do we work with those different communities so that we can make it fit for purpose. So, when I think about a city like Melbourne, that is, a very large city, but it's a very diverse city. And so, yes, there are going to be population approaches, but how do we go out into the different communities within a big city like that and tailor approaches that are going to be effective for the particular community at focus?
Yeah, and this is something that we've been talking about for a long, long time. Prevention, clearly, prevention is going to be better than treatment, and we know what we need for prevention in a large number of cases: diet, lifestyle, exercise. But even with the evidence, even though we know what needs to be done, very few cities have managed to turn that needle on cardiovascular.
Yeah, that's true. We talk a lot about people knowing their numbers, yet we know the vast majority of people don't know their numbers. I had the opportunity to work on the World Heart Federation roadmap for cholesterol. Cholesterol's important. We know that familial hypercholesterolemia is a highly preventable and common cause of premature cardiovascular disease, yet in most countries in the world, we've identified no more than 1 or 2% of individuals with FH. So how there is a clear disconnect between what we as the experts are saying and that message getting through to the community. So they're either not hearing it, we're not delivering the message in a way that they're receiving, and I think we're not bringing people along with the solutions. And again, I think that we've got to think about what health literacy looks like, we've got to think about what communication looks like, we've got to think about solutions that may be really good in one sector of the community, may be hopelessly inefficient in another. And so how do we work with those communities to try and understand what are the barriers rather than trying to come up with solutions that we think are going to apply to everybody?
It's got to be attainable as well, though. I mean, if you consider that, for example, processed food is a lot cheaper than fresh food, these have got to be goals that particular communities have to be able to attain without hardship. It
does, and we've got to think that, and that's why it's going to be our all-of-population approach. Government, we've already heard about it from some of the other panellists. Governments, they've got their role, the medical community's got their role, the community's got their role, and it's all of those bits coming together. And what alarms me is that as we start to talk about more and more factors and novel factors that we think are driving the disease, how do we deliver on those when we haven't been able to deliver on the simple messages that we've already been trying to communicate with? So I think if we can come up with better coordinated approaches but bring all the stakeholders in, I think that gives us a better chance.
And we will be talking more about collaboration during this session. Thank you, Stephen. Lillian, let's get the view in Kenya. Hypertension, high cholesterol, diabetes, these are all major issues in Kenya. Tell us how the risk factors are prioritised and the main challenges.
Thank you so much, and I'd like first to congratulate Dr. Anne for this initiative. I think if you can triple BP control in such a short time, that's really amazing, and I hope it'll come to Nairobi soon. So anyway, just to give some context, in Kenya, 41% of deaths are due to NCDs. So we still have 60% which is due to other causes, including communicable diseases. So we are trying to deal with all these things. And if you look at cardiovascular, 25% of admissions are due to cardiovascular diseases. And what we are dealing with mostly is heart failure due to hypertension, stroke, And then we have this group of the neglected CVDs, rheumatic heart disease, and congenital. So I think it's good to always consider, what kind of CVDs every context is dealing with. Risk factors: 1 in 4 Kenyans have hypertension. A third of Kenyans are obese or overweight. We have low intake of vegetables and fruits. But I also want to mention that this is data from 2015. We haven't done another step survey, so back to data, the importance of data. So for almost going to 10 years, we don't have, and we are not routinely collecting this kind of data. So if you don't do any step survey, then we don't have data. So we don't know how we are doing. That's a big, that's one of the gaps we have. And so in terms of challenges, again, I said we have a double burden of disease. And at the same time, our governments are not putting enough funds to health. So even as we try and drive the NCD agenda, we are dealing with a very small pot of funding towards health. And that's really a challenge we have to face. Lack of data, I think I've already said that. We have low awareness levels on both cardiovascular and the risk factors. We don't have enough specialized treatment, access to specialized treatment, access to specialists. So that's another what we are dealing with. In terms of prevention, we are doing well with tobacco, in terms of public smoking, access, taxation, but we are lagging behind in terms of alcohol. So we have a lot of alcohol advertising. There's still quite good access to alcohol. We are not protecting children from the advertisements and all that. Healthy diets, we don't have policies on salt regulation and trans fats yet. Still working on that. Access to medicines. So at least we have, as a country, we have prioritized the access to cardiovascular drugs at the primary healthcare level. Right. The challenge is that sometimes the availability of drugs is erratic, but at least there's commitment to make sure the drugs are available at primary healthcare level. So those are some of the challenges that we... So it
sounds like there's a lot for your government to be thinking about, and clearly the lack of data is hampering sort of comprehensive efforts. But so what approach are you taking? How are you trying to improve cardiovascular health at a population level?
Yes, so as Kenya Cardiac Society, we've been working with the government. First, we participate actively in the development of strategies. So when we are developing the national NCD strategy, we really work with the government to make sure they are prioritizing the right interventions. We have guidelines for most of the NCDs, including cardiovascular. Actually, I think we are probably one of the few African countries with comprehensive cardiovascular guidelines. We've just revised our second edition, so that's something I can say is we are doing well. Our countries are now focusing on universal health coverage. So what we did as Kenya Cardiac Society, we made sure we are in the conversations to make sure when they're developing the benefit package, they're adequately catering for cardiovascular conditions. So that's another thing we are doing. So making sure they're prioritizing cardiovascular conditions in the wider WHA initiative. In terms of school curriculum, I think we've done well. Actually, the curriculum has, like, physical activity was never a subject on its own, but now actually physical activity is a separate subject taught in schools, and it's actually examinable. So,
really?
And that was,
you have to have an exam in PE?
Yes, they have an exam on physical education.
Fail.
So, and for example, my children, most of the days they wear the sports. So they're having sports on more days than previously. And also on diet, there's a lot of focus on healthy diets in the curriculum. Right. So I think that's a good thing that has happened. I think I've probably mentioned the rest. So yeah, we are working with the government to just make sure we do what we can with what is available.
Thank you. Thank you very much indeed, Lillian. And clearly data is king, because that is what helps drive resources to the right places. Otherwise you get a sort of, with all due respect, a scattergun approach to trying to solve population health issues. What are the main issues you've come across that health authorities are struggling with?
Thank you, Julie. Yes, I think we heard it from each one of of you in the panel. It's really the unknown. In most of the cities where we start working with, they don't know how many people they should see in the system. Or when they know, they cannot identify the total number of people with the cardiovascular risks that are diagnosed and treated in the system, because the data are all siloed in different systems, like you described, between primary healthcare or hospital system. So it's really that unknown. If you want to put targets in your objectives that you want to reach at least 90% of the people with high blood pressure or high cholesterol, you have to also know how many you already have in your system. The second unknown is obviously the people don't know their numbers, as Stephen was saying, and that's the number of undetected people with cardiovascular risk in the system is a problem that is ubiquitous. Even in high-income settings, it's not uncommon to see 50% of the people whom you would expect to be diagnosed to be undiagnosed, to not exist yet or not be identified yet. And that is the main danger for people, that they continue running around asymptomatic at high risk for cardiovascular event and end up in hospitals. So when you walk through African capital cities, I'm sure, Lillian, you agree with me, they are not filled with HIV patients anymore. They are filled with stroke patients. And there is often no rehabilitation services, no way out to get that under control. So we need to act much earlier. And as soon as we start working with the real-time data in the cities, it shifts that. You can have real targets and monitor your progress towards them, and then redesign your interventions accordingly. And that was the success of Cardio for Cities. The last unknown is really in many different settings, is that we don't understand the drivers of inequities, like you were describing, Ashwin. They are very area-based. There's people who have very different outcomes, do cardiovascular events much earlier, worse outcomes in hospital, have even similar access to care, like here in Switzerland, similar access to good quality care, and still very different outcomes when you send them home to the conditions where they live. So we need to understand that part much better. What Michelle said so well in the beginning, we need to really understand which of these determinants we should try to act upon to improve our cardiovascular outcomes. So all of these unknowns are ubiquitous in every city. Some cities do better in having their data centralized and answering the question, how many people do you know? But some cities don't. And it's amazing how even in very rich countries, it doesn't always correspond to what is real world.
Do you think cities or authorities in general agree that the system's not working and are open to a different approach like Cardio for Cities?
I think so, yes. Most people, definitely all of the people we have talked to, are very open to that. It is a question of better understanding. If you want to decide where you have to put your dollars to, everybody wants to understand the situation better. So we see a very keen appetite to work both on AI for healthy cities together and on Cardio for Cities, because this simple strategy to implement the things we know that need to be done is very attractive, and that it's based on the actual situation of your city, what you're already doing and what you could do a little bit more or less of. That is very attractive to all of the players we meet with in cities.
All right, so alongside data, obviously there's an importance in collaboration and cross-sector approaches. Yeah. And Ashwin, I wanted to ask you, it's highly likely that the data that you're collecting is going to show that there are other sectors involved in health, and we've talked a lot about those other sectors already, things like education, housing, security, nutrition. But those budgets handled by different departments. So how should city authorities work together to try and get a more holistic solution, a more holistic financial solution?
Well, it starts by setting a goal that everyone can see and everyone feels a part of, which is why we set out life expectancy as a unifying goal that is certainly not in the purview of any one department. And establishing mortality reduction goals for the leading drivers of premature death as well is not under the purview of any one agency, but everyone feels invested in those goals. So we were able to get every single city agency around the table and say, I can see myself in this somehow. And even if they don't know, that's where I certainly saw an openness to learning. That comes in part because, particularly coming out of the COVID era, people want to feel like they're a part of constructing a healthier city. No one wants the repeat of the pandemic where we saw this kind of, not only the amount of death and despair, but the inequities in a place like New York. But two, we also had very strong executive leadership. So this is, while my authority as the leader for health in New York City is, we're the designers and the leaders of this, it's the mayor who has taken this up as his initiative. And we've made sure of that. We've made sure that it is his. And the other thing we did was we passed a law to encode Healthy NYC into our civic planning. So now it becomes a permanent feature of the way that New York City will operate long after I'm gone and the mayor's gone. The next guy or person will have to do the same thing. They'll have to come and answer the question, are lifespans increasing, are health spans increasing, and how do we know, and what are the drivers, and how do we organize around it? So I think that that's key. It doesn't work without data, however. Yeah. And I want to get to, you asked the question of Anne, of what do city health authorities think about the most. We do not have any discipline in the way that we make comparative choices about how to appropriate our budgets for health. And so hospital X will come in and say, I've got a great idea, let me build a heart hospital. And that will improve population health, because look at my outcomes, they're fantastic. Yeah. And then someone else will say, well, you know what we need to do is ban sugar or issue a tax. And what we do not have is we have not yet had the ability to impose any sort of comparative discipline, fiscal discipline on how we make those choices based on the return on mortality and morbidity and mortality. And so underneath our Healthy NYC initiative, using the data from initiatives like AI for Healthy Cities, myself and the budget director are in very close partnership doing economic and population health modeling.
Return on investment.
Looking at, even if we don't boil the ocean, right? There may be things that we find in AI for Healthy Cities mapping that are not in our view. There may be risk factors that we haven't thought of yet. Right. But we know many of the risk factors for cardiovascular disease. But we don't know how to apportion our attention to each one or our resources. And we are beginning the process of modeling out how we might get to a 5% reduction in cardiovascular disease deaths by 2030 by apportioning our investments, at least in the purview of what we can control, to make a difference.
And make it more analytical. Thank you. Dr. Althani, the Qatar National Vision 2030 obviously envisages a healthy population. How are you integrating different sectors into that, like social, economic, environmental development? How do they all play towards health?
Yes, thank you. As you know, Qatar was one of the first country in the region, the GCC, to put the Vision 2030 before SDGs 2010. And now we are working together through the strategy. We have a governance called Health in All Policy, which other countries in the GCC start doing. The Health in All Policy led by the Minister of Health, supported by the Cabinet. The other minister will be represented to support the health, because we believe health is in all policies. You cannot do it only from yourself. So we have many work is done with Minister of Interior for traffic accidents. Many things happened with municipality for the healthy cities. We are working with, more parks, more places for bicycling in Qatar, and more safe thing for colleagues like this. We are working with the Ministry of Finance for more taxation for tobacco, sugary drinks, and maybe hopefully soon trans fat, maybe either prohibited or to be on taxes. So we believe that without working together with every sector in the region, the universities, for the new research and other, this will not work. One of the reasons that Qatar have always lucky to move forward is the good alignment between everyone, and how we created not only the structure of the ministries or the institutes, but we have a governance bodies to highlight what could be done in the structure, but you make committees, working groups, and task force that can help you to deliver what you need to do during this period. One of the things that we are trying now to work with our Ministry of Telecommunication, how we can make all our information from the mobile is connected to our computer, and whoever say, I'm walking, doctor, give me your iPhone, let's check your smartphone, are you walking enough or are still at risk? So by this way, you can know the early risk factors from checking their smartphone practice or watch or Whoop or these things. So these are what we are trying to do through the communication with other members, and plus new applications is happening for food and nutrition and control of tobacco. Thank you.
Thank you, thank you. Jagat, I asked Anne the question, how open are cities and authorities and governments to the idea that a new approach is needed? What do you think is the appetite for approaches like Cardio for Cities?
So, in the high-income countries, or for that example, for example, in the United States and all, there is a growing appetite for the novel health initiatives or innovative health initiatives, which leverage the real-time data and prioritize equity. Now, the interest is fueled by the increasing recognition of health disparities, advances in data technology, and a push for more sustainable and inclusive urban health policies. And COVID-19 really exemplified that need. So the appetite for Cardio for Cities would be significant. Now the question only is that we did talk about that we need to know our numbers. We do have a policy that can come in, but the question is that even if I knew data, even if I had a policy there, what exactly I really need to know, and what people feel about it. How am I going to educate these people? Important thing is when you talk to the patient, what is your cholesterol level? Even if I knew the cholesterol, it's borderline. Blood pressure, borderline. Sugar, borderline. It is the borderline of too many things which is more important than an extreme elevation of one risk factor. Right? Or if we talk about, I'm 65 years old, I'm 70 years old, what is left anyways? If you age well, if you have the risk factors taken care of, you'll do well, whatever age you are in. And then there are other people who come to me and they say, my dad had it, my mom had it, and I'm doomed. No, even if you had the genetic risk factors and all, you treat your risk factors, you treat the disease, right? So the way we really need to go after this is how novel we can become. And accelerators like Cardio for Cities are going to put the minds together. We are all going to get together and see what works and what does not work. I'm born with 25 milligram of LDL. Why is it that in first 3 years of my life, my LDL goes to 130, 150? I'm not feeding the so-called fat that I'm trying to reduce in my policies and all those things. What exactly is going on? Have we even tried to address those things? And then you talk about the countries like the low middle income countries, as you asked me, and for India, for example, the enthusiasm for similar approaches is absolutely notable. But in countries like that, it is riddled with the unique challenges, but provides me the greater opportunities also to intervene. And rapid urbanization, high level of pollutions, and inadequate infrastructure, coupled with the significant health disparities, creates a pressing need for the approaches like this. We have got to become more innovative. We've got to become more novel. We've got to work together. We have to collect data, and that data is the soul. And the appetite is there. The only thing is that we have to come up with the right kind of solutions here, which are rightly tailored.
Yeah, very true. Stephen, you talked about the goals and what needs to be done in your region. How do international partnerships like the Cardio for Cities Accelerator further those goals?
Well, I would extend it even further. I think the concept of public-private partnerships are going to be critical. I think if we're trying to find new solutions in cities and we're asking cities who have limited resources in the first place to try and come up with new solutions. They need to be smart. And I think that, in most jurisdictions, I think you're seeing, governments who are much more open to solutions coming from partnerships that they didn't have before. And so the role of the private sector coming to the table on a range of things, and I think data is a really good example of that. I think that where we can learn from good solutions elsewhere in the world, a great solution should be copied. It should be tailored and made fit for purpose, but our ability to share and exchange and then to try those new approaches elsewhere are important. So I think this is a global problem. Unfortunately, the burden's rising. Alarmingly, we're seeing the mortality rates in countries which had been plummeting for decades now plateaued. In the US, we've now seen the death rates due to heart disease actually start to rise for the first time in a generation. I've not known in my clinical career death rates to be rising in the US, but they are now. And so, these are alarming numbers, and so we can work together.
Thank you. Lillian, do you think the Cardiac Cities approach would work in Kenya?
Yes, absolutely. I think the reason I find this initiative unique is the local ownership. I think a lot of our countries, Kenya included, are really interested in coming to support what we're already doing. Because like Kenya, we have good policies, policy documents. So anyone coming in, we would like them aligning with what we already have in our strategy, in our plans. And secondly, sustainability. So we always look at, okay, after this 1-year project, after this 2-year project, what can continue? So that's really important to be discussed at the beginning, so that it's clear that after this period of possibly there could be funding, there could be support, are we going to be able to continue with whatever has started? And then secondly, the other reason I find this really, it'll align well with Kenya, for example, is data. I think we've really come to a point to really acknowledge that we need data for planning, for decision making. So the possibility that this will help us get data on health and cardiovascular care is something that I think will align well.
It's astonishing that data's not collected already. Is it really that basic? So
our systems have focused a lot of communicable diseases, HIV, TB, malaria. They were heavily supported, donor supported. So for a long time, with donor funding, we didn't really invest as a country ourselves in the data systems, but now we are having to create our own data systems for NCDs because there's not much funding. So we are the ones who are having to put up those data systems. We are trying to leverage on HIV systems, but you can see how that is something that has to be worked on. It's not been there ordinarily.
That's really interesting.
Data on risk factors like smoking, intake of vegetables is not data people collect routinely, at least in our setting. So how coming up with ways to have this data collected routinely is something we need to work on.
Yeah, that's really interesting, the focus on communicable diseases. Thank you, Lillian. Anne, give us some examples then of how cities are looking for innovative approaches to address the CVD problem.
There's many examples,
well, we won't have many.
No, one I always like to give is what the teams did in São Paulo. So we understood that we were not diagnosing not enough people. So in the health centers itself, they installed a screening corner for everybody passing in these health centers to get their blood pressure and now also blood LDL and glucose measured, that then could automatically be referred to the consultation if they wished. And with that, most of these health centers are quite big and they have a lot of foot traffic. So you have thousands of people a day passing there. We identified a lot of people with cardiovascular risk like that. And we realized we only found the women, because it's the women coming to the health facilities as caregivers or as a visitor or as a parent or a patient. And we were missing the man. So where where are the men? We went out to the football stadia, the samba clubs, the high traffic venues in the subway stations to diagnose people with cardiovascular risk, and that was very successful. So that kind of innovations is always fun. Nowadays, you can diagnose by phone. You can use an AI-driven very short video of your face that tells you all your cardiovascular markers. So now we can do this in a different way. But this is still very necessary. In Helsinki, last week I was there, they do the same. They have a screening corner, which is more sophisticated. It's like a cube where you get an ECG and everything done, but they have everybody passing in that cube before they can attend to the reason why they came to the health facility. So it does work.
I love that idea of lateral thinking, going down to the samba clubs and finding the men. That's great. We're sort of coming into the closing stages of this. I'm going to give one last comment to all my panelists, and then we're going to take some questions from the floor. So please have those ready, because they are all ready and willing and able to answer questions. And what I'm going to ask for is a final thought from all of you. And if we could keep it to a minute each, that would be brilliant. Especially you, Jagat. But I know that you're going to do it. So let's start with you, Ashwin. So what would you tell other cities wanting to learn from the success of Healthy NYC?
Number one is it can be done if you choose to take ownership of your health outcomes at a city level. It's so interesting to be here at the World Health Assembly. It's my second time here in my role. And to hear a bunch of state actors and national actors talking about cities rather than city officials here is quite jarring. But it also tells you something. There aren't many cities, and the McKinsey Cities report that was launched a few days ago also highlighted this. Cities with strong health authorities do much better in terms of affecting population health, and not every city is governed that way. We are lucky. We have a strong executive, strong health department, strong agencies. But you take a Los Angeles or another city, and it's very much a function of the state or the county apparatus. So we do have to think about the governance of cities. But I would just encourage people in roles like mine and in executive offices, it can be done if you focus on it. You do have to, you can't manage what you don't measure, right? That's our old mayor, Mike Bloomberg, used to say that. You can't manage what you don't measure. And so you've got to be bold, set goals, and even if you don't achieve them, you will fail forward. You will make progress at a time when we're not making progress. We're actually moving in the wrong direction in New York City and in the United States. The last thing, I'll just end where Dean Williams started. We have to, and I'm stealing from the Singapore health minister, because I love this thinking, we have to shift the gradient of spending, of attention, and of investment and resources towards communities, towards social needs, and towards prevention. And that we will find that that is the greatest ROI on preventing and averting cardiovascular deaths. And no one's in better control of that than people who are close to communities and local authorities. So cities have a massive role to play. And so I encourage everyone to kind of look at Healthy NYC, see what you agree with, see what you don't agree with, but talk to us and we'll work very closely with you.
Thank you, Ashwin. Dr. Althani, what advice would you give when it comes to transitioning to a robust preventive health governance system?
Yes, thank you. I believe now, as countries has been working very well to lower early deaths from, from infants' deaths and maternal death and even road traffic accident death. By the sophisticated system that we are having now, we can make more preventive measures for all the cities. And I believe all the cities now, when they are going to any election, they not only promise to clean the city and make it more beautiful, they should promise that they will lower the early mortality for every person in their city or their county. And this one should be always there. And as Dr. mentioned, I say always a mega of prevention is better than a gigabyte of treatment. Thank you.
Thank you. Thank you very much. Lillian, what is your hope for accelerating cardiovascular health in Kenya, or indeed across Africa?
Yeah, I just want to add something about the question about data. The other challenge we have is because most of our data is manual, not electronic. So that's the other challenge with it being, be able to aggregate and analyze, yeah. But for me, what I take home is, and for countries like us, it's just local ownership. I think we've come to realize there's not much funding coming for NCDs, so we have to work with our local leaders, come up with the local solutions, work with communities. Sometimes communities have solutions which you don't necessarily need funding, but they're able to come up with innovative solutions. So work with communities and learn from others who have succeeded.
Thank you, Lillian. Stephen, specific outcomes you're hoping for through the Cardiac Cities Initiative?
To bend the curve, this is
Sorry, push your button.
To bend the curve. This is a preventable disease. We can't more consistently make that point. So, but we do need a whole of society approach to that, but we all need all players to kind of come together. Anne talked about the Samba classes. I think one of the most impactful studies in our space in the last decade has been the management of hypertension in black men in barbershops in the United States, and they were able to take pharmacists into the barbershops to work with those men. They ended up with better blood pressure control. We need to find our barbershops in our societies, and we need to actually have them come to the table and be part of designing the solutions.
Thank you very much indeed. Jagat, the WHF's vision to improve heart health by 2030, is this the way to do it? Is it achievable?
The World Heart Vision 2030, it is a multi-sectoral action plan towards improving the cardiovascular health, and focuses on 4 main things. That is the paving the way for cardiovascular health equity by understanding and addressing the drivers of inequality, fostering timely implementation of knowledge, leveraging innovation and technology for cardiovascular health, and placing cardiovascular health at the heart of health and climate policies. But before I stop, I just want to give 3 important lines here. One important thing is that we need to start the day the child is born.
Yeah.
Whether is it the breast milk, which is going to make the difference, what are they consuming in the first year and what all, and when we come with the innovative plans with the Cardio 4 cities, we really have to start thinking much broader way than just following what has been told to us, 1. 2, it is not a problem of a cardiologist. The cardiovascular disease, and Steve and I were just discussing before we started here, this is the problem of the primary care workers or primary care physicians, healthcare workers, and as he just said that we have to find the barber shops and things like that. The problem starts there, and we really have to figure that out. We need to incorporate that into our accelerators. And finally, when we talk about the risk factors also and we start treating them, we really have to start thinking about some novel ways of doing that, because all the risk factors, they are asymptomatic risk factors. They don't cause symptoms. We treat the risk factors, we make them symptomatic. You give them statins, some person comes with the muscle pain. You have the hypertension, they come with dizziness. You give them the hypoglycemic agents, they start feeling dizzy again. So all these things that we talk about, we need to go beyond that. Secondary prevention is understandable because the people know that they have a disease and they have a problem, they need to be treated. Primary care, we will need to go beyond. There are new agents which are coming in. We need to work with them. For example, the RNA therapeutics. There were 2 studies which were presented yesterday, zodasiran and plazosiran yesterday, inclisiran. There are so many of them which are becoming available. As the cost starts to come down, I think we'll be able to bring them to the population level and work much better. And finally, we are working with the various global initiatives like Sustainable Development Goal, and this morning we were with the UNICEF also, and all we started talking about the interventions in the children and how do we do that. Stop there, she's looking at me.
I'm looking at him, yeah. There'll be another email on the way. Thank you very much indeed. And finally, Cardio for Cities has had such encouraging results so far. Where next for the initiative?
Yes, well, first of all, we want to bring Cardio for Cities to 30 cities within 3 years with the Cardio for Cities Accelerator, with these fantastic partners of the World Heart Federation and many others, to make sure we get to that 2030 goal. At the same time, we want to make the Cardio for Cities model a continuously improving model, a learning model that integrates the data insights from our other initiatives like AI for Healthy Cities or other data sources like the ones in Qatar on the genomes and the biobank data for understanding cardiovascular risk factors and cardiovascular disease better. Because what would happen if we were able to equip our decision makers, whether that's health system managers, public health decision makers, mayors, we have to equip them with precision population health tools that they can really target the interventions and the allocation of resources to those areas, those populations that need it most. And that would help us, I'm convinced, together with these innovations that Jagad is mentioning, the new ways of administering treatment that is going to become much more easy if you have it once a year or whatever, that kind of innovations together with these precision population health tools, I'm convinced it will help us eliminate cardiovascular disease in the next generation. We just have to make it happen and work all together because one partner cannot do this alone.
Thank you. Thank you very much indeed to all my speakers. Now, I know it's been a long evening, and I promise we have drinks and refreshments for you in the next room, but let's see if there are any questions from the audience. Yes, front row.
Thank you.
There's a microphone on its way. You probably don't need it, but why don't you take it? There you go.
Thank you. Very exciting. Thinking about how do you create this ecosystem for better cardiovascular health in a city. I think going to the idea from the New York Health Commissioner about how do we compare these different interventions. I think one thing that I didn't see mentioned was air pollution, which is the second highest risk factor for cardiovascular disease globally. There's just recent data from WHA again. So I think that is an entry point to sustainable transport, to better housing, to a number of others, to more green areas. So I think including that equation within the thinking, which is ecosystemic, you know, where does the early prevention or the screening comes in, and where is it? There's those other risk factors come in. Yeah. Because if you have baseline air pollution levels increasing everybody's risk factors or conditions, you know, you would have a poorer answer from your medicines as well. So I just thought I would throw that in as one of the elements.
Does anyone want to? I mean, I know that the World Heart Federation has air pollution. Air pollution is one of the things that of a key report this year.
So this was our major focus, and actually Jean-Luc just passed the booklet that just came out of World Heart Summit just now. And we have been working closely with the objectives set by the Conference of Parties to the UN Framework Convention on Climate Change. And absolutely that this is a priority, not only the outdoor pollution, but the indoor pollution as well, which basically is going to be extremely important, specifically to bring down the prevalence of the cardiovascular disease in women who are exposed to the indoor pollution significantly. So obviously, I mean, I think we passed it in, we mentioned it in passing. We should have been a little more aggressive about it. But certainly in the low and middle income countries specifically, as they are urbanizing rapidly, the load of pollution is increasing amazingly.
Thank you. Thank you for the comment. One more question. Trevor. Trevor, and then the lady at in the third row.
So I've got about a minute of context followed by a question, and we got close to this at the end, Anne, with your comment about precision tools. Strongly support the comments about data, but to build on that, the science and the evidence of effectiveness and the tools that can get us there. we heard before, implement, implement, implement. So I led in Australia for 8 years an initiative called Healthy Active by Design. It explicitly targets healthy urban planners, developers, local government officials, those that build the environments that we live in. It's a web portal. Why? Because we went 15 years ago from a period where we had scant evidence in this area and few good case studies to right now we have a lot of both. So what was needed is a portal, a resource with, we call these design features on predictable things like transportation and healthy food supply, case studies, examples, evidence, tools, and precision tools, case studies, videos, and training. So I guess coming to my question, because I didn't mean to give a lecture, is what is the potential for something like that as an adjunct to Cardio for Cities and the excellent initiatives that we've heard here, tailored, as Steve and Jagat said, to local need and circumstance?
Thank you, George. Ashwin, do you want to take that?
Yeah, this is something New York City has also done, right? We have something called the Active Design Guidelines, and we just last year passed our second version 2.0 of that. So designing healthier environments, designing more walking communities, we're starting to incorporate, you know, some of the concepts of 15-minute cities into our work. The challenge we see at the city level, and I'm sure it would scale to other jurisdictions, is enforcement. And when push comes to shove around getting building codes and zoning changes and unlocking capital investments into new construction, that's where this becomes very challenging. Transportation, subsidies for more bike lanes and so forth, that's where this becomes very challenging. But there's no shortage of will in terms of our active design guidelines. It's been, the follow-through has been very challenging. And so what I worry most about this work is that it sits on a shelf or a web and doesn't get actually enforced and encoded into the way that we build New York City or any city.
Thank you for the question. The question from yourself?
Hello, my name is Bronwyn Hennig. I'm the director of the Global Health Policy Lab, a new initiative based in Berlin. My question is to Anne. In terms of the expansion of the accelerator, how will cities be selected? You know, what are the criteria? Will there be self-selection to some degree by cities coming forward? Will there be criteria that you have at your end to say you want to have diversity in epidemiological profiles or geographical profiles? How will you expand the family of whole of a city?
Thank you, Bronwyn. That's an excellent question. In fact, we're working on all that, on all the strategy of, at the moment, it's opportunistically who comes forward, where there are opportunities, also resources to do this. That's where we prioritize at the moment. But obviously, our goal is to also have a geographical spread all around the world, definitely.
Can I just add, you know, I think there's an opportunity for us to be really proactive, though, and force the hand to make sure that we really do get that diversity. So when we were approached about Melbourne being a city, I thought, that's fine, but why don't we bring somebody along with us as a partner and pick a Western Pacific country. So that's exactly how we intend to do this, is to get Melbourne up and running, and then pretty quickly after that, you know, get a buddy. And actually, we think that by doing that, we can help provide some infrastructure administrative support for a friend that might not have quite the same resources that we do, but at the same time, we were not just looking after a high-income city. Yeah.
Thank you very much indeed. Lady in the second row. And we'll make this the last question, I think. Thank you.
thank you for a wonderful panel. I have one very, very brief comment and then a question. So one thing that I just wanted to say, so I'm Sindhu Ravishankar. I am the Vice President of the Fast Track Cities Institute, so a fellow cities person, and very excited to be here and hear from you all. And one of the things that I've noticed even just throughout the last couple of days is that there have been multiple different city initiatives, and there are a lot of common themes. So just want to say that I think we should really be sharing information. There's Fast Track Cities, which has focused on HIV, TB, hepatitis, although we're broadening, so appreciate any partnerships. I saw CCAN, which is focused in cancer. There was one focused on obesity, and a lot of same themes that are really drawn throughout everything. So data, timely data, especially real-time data, locally led strategies, focusing on the city because you can have implementation and measure impact. So I just wanted to put a plug there to say that I think we should really be sharing our experiences and leveraging the infrastructure that we're building in the cities that we're working in. And then my question for the panel is, when we're talking about locally led strategies, really that's coming through community engagement and participation of community. So I'm just wondering if there's any examples of how in any of your jurisdictions you are using community engagement to ensure that the initiatives are locally tailored. Thank you.
Would like to talk about community engagement? Anne? Lilian? All right. Lilian, you want to go? Lilian? Yeah.
Yeah, I'll just talk about the project we've done with WHA. They've supported us to disseminate the cardiovascular guidelines, and we did that in 9 counties. And what we did, we actually went to the counties and had a discussion with them. We didn't really have a blanket intervention or approach for all, so we actually brought them on the table, and we were able to see what do they have available, what are their priorities, and aside from what we did, we actually went above and beyond to make sure we offer them what they need. And we also later integrated community level interventions around awareness and screening. And this again was driven by the needs they had. So they are the ones who said, this is what we want to screen and we want to have at the community level, and that's what we supported.
Thank you.
Yes, from our side, also these first Cardio for Cities initiatives, they were completely community-driven and locally owned. So we sat around the table first with the authorities to see where the gaps were in the patient journeys, the population health maps, and then we identified some areas we could work upon, and we used design thinking in some of these cities to design the innovations that would address those. And then we went with those to the community representatives, and they said, well, we think that kind of solution would be better addressing in or going in that direction. So they changed the way we understood the problem, the way they saw they could act upon it. And that makes the Cardio for Cities roadmaps very localized and very applicable according to what the people who live there need. And lastly, in AI for Healthy Cities, we don't only want to use the quantitative data to have the computers tell us what we should be looking at. We are also investing in a large-scale qualitative survey by an anthropologist institution who is going to speak to our community representative, but also to experts, to understand what is, according to you, influencing your health most, so that we don't miss anything, that we don't miss any invisible population. And combining that qualitative data with the quantitative one is going to be hugely important for evolving our initiatives.
Thank you. Thank you very much. Thank you for the question, and thank you, Anne. And I want to thank all the speakers.
Sorry.
I'm so sorry. Because I've got people on either side of me. I need eyes in the back of my head. No, sorry, Lilian, please go ahead.
I also wanted to add that we work with persons living with cardiovascular diseases, because by addressing exactly the areas, they can really present the challenges they're having, and that also informs how we deliver our interventions.
Thank you. Thank you very much. Apologies for that. Any more comments? Lovely. Listen, thank you. You've all been brilliant speakers, and I think you've really put into context what the opportunities and the potential is for a programme like Cardio for Cities initiative. I'm going to hand back to Anne to close proceedings, but please give a final round of applause to our fantastic speakers.
Thank you so much, Julie. And with this, I would like to invite a special guest, is Patricia Duerte from Swiss Re Foundation. As Swiss Re Foundation has been our first partner who is investing in replicating cardio for cities already in 2 new cities. So Patricia, please.
Thank you. Nice to be here, and I'm delighted to share a bit more insights about our collaboration with the Novartis Foundation. I am Patricia Deutsch. I represent the Swiss Re Foundation. We are the global grant-making foundation of Swiss Re, the global reinsurer. And what the foundation is about is actually to try increase societal resilience in low and middle-income countries. And we are not doing it by ourselves. We are keen to have partners that are doing the intervention, and in the access to health portfolio, where we are keen to support the inefficiency and in the healthcare system, we are very much keen to try to help good implementers to bring people's access to healthcare where needed. And actually, 1 year ago, we have heard here in Geneva about the Cardio for City Accelerator program, and we were very much keen to learn more. And since then, we have actually craved a partnership with the Novartis Foundation and its local partners in Brazil. And this February, we started with the replication in 2 cities, in Patos and Aracaju. That's actually cities that are located in the northeastern part of Brazil, where actually health outcomes and healthcare quality are lower than the national average. And actually, why did we invest in this approach is actually 4 reasons that stand out for us. So first, it's the strong evidence that the São Paulo case was showing, so that the approach is really effective. Second, it's the comprehensive way to identify local needs, to build solution with design thinking, and then also to provide the package of solutions that are aligned with global recommendations. And third, obviously, this topic of local ownership is very much important. So we see this is key, and in this project we see that is really happening. So the local health authorities are driving the process of finding solution and then possibly integrate it in the health system. And the fourth approach is, it acts actually as a Kickstarter. It is a catalyst to build best practice in the cities. And we are actually happy to see that after only 3.5 months in the project implementation, we see results. So health authorities in Patos and Aracaju, they are eager and they have signed collaboration agreements. We have 80% of the solution designed already implemented, 49 and healthcare facilities and 200 healthcare professionals have already been reached, and some certain cases been trained. And this means that we are currently already reaching 370,000 people. And this is, we were quite impressed to see that this is happening that fast. We were a bit skeptical in the beginning, but it's great to see that it's really, the team knows with the experience that they had in São Paulo what they need to do. And what's next is actually that the team is closing by end of June and will implement the remaining solutions. And then they will hand it over officially to the local stakeholders. We said for us it's also important to make sure that several health indicators will be measured. So over the next year we will try to do that, and in order to measure the impact of the intervention. And we said ourselves in the foundation, so assuming that the results continue to be so promising, we would be open and willing to do more investment and support the scale-up of these efforts. But however, we also recognize that philanthropic players alone cannot do it, so everyone here is actually needed to help, and therefore therefore, I guess I would conclude in saying, yeah, we need more collaboration. We need to pool resources and expertise together to improve population health in underserved communities. Thank you.
Thank you so much, Patricia. Big applause, and thank you to Swiss Re Foundation. We are really thrilled to hear about your results already. This is fantastic. And I cannot underline more your last sentence, Patricia. We need all of you. No one can do this alone. We need to work together to get cardiovascular risk and cardiovascular disease better under control. So let me invite Jean-Luc. Please, we will close this session. Jean-Luc, you can go first.
Well, thank you very much. That was really an exciting evening. We heard about the challenge, first cause of death worldwide and probably first cause of death in any cities. We heard about that it's not only death, but it's pain, suffering, inequities, working hours which are lost, children time which are lost. So something which is really serious, not only at the level of death, but also at the level of the impact on our cities. But we also heard about solutions. We heard about things which work. We heard about how you can early diagnose and manage disease, cardiovascular disease. The case of Brazil was very interesting. And if I think about Nairobi as a city where, if I'm correct, 25% of the population is suffering from hypertension, and about 10% is been diagnosed and 4% is managed, you realize how an efficient system in a city can make a difference for the life of the population. We heard about the importance of data and the way AI can help identifying solutions, and we heard that data and solutions are not only medical driven, but they are based on the environment, on transport, on air pollution, on prevention measures, on legal frameworks to help improving cardiovascular health for everyone. So on behalf of the World Heart Federation, let me thank again Novartis and the Novartis Foundation for their support for this event, all the speakers, Shuli, for your smooth and timely management. And thank you again, and we'll have the opportunity to meet together and share both thoughts after this event. Thanks.
Yes, and I don't have a lot to add anymore, but a very big thank you also to all the team of the World Heart Federation who organized this event. Thank you, Andrea, and your team, and the team of the Novartis Foundation who's been supporting the event. Thank you, everyone, and a warm round of applause again for our panelists. And please join us for the apéro that we can continue the conversation and exchange and connect for further streamlining of initiatives. Thank you for that comment.